Today, this is Dr. Suman. I'm working as a consultant pediatric intensivist at KIMS Cuddles Gachibowli. Today, the topic for discussion is status epilepticus. Which is a most commonly discussed topic and most frequently seen scenarios in our daily practice. The next 20 minutes, 20 to 25 minutes, we would be talking about what is basic terminologies, definitions of seizures and status epilepticus, and an important brain concept called time is brain concept. Third, we will be talking about what is the basic pathophysiology for these seizures or status epilepticus. Fourth, we'll talk about the management and reviewing few guidelines if time permits us. So with these objectives, we'll go ahead. So terminology part. So what is a seizure and what is an epilepsy? So seizure is like an abnormal excessive paroxysmal discharges, electrical discharges, primarily in the cerebral cortex. Whereas in epilepsy it is a condition which predisposed to generate the seizures. So all epilepsies will have seizures, but all seizures are not epilepsy. So to call it as an epilepsy, at least two or more unprovoked seizures, which are 24 hours apart in an age more than 1 month, is called, we will think in the terms of epilepsy at that point of time. So convulsions is involuntary muscle contractions, which can be sustained in tonic contractions, whereas in unsustained contractions like in clonic contractions. It's a basic terminology. So now coming to the definition of status epilepticus, you see from the very past, in 1981, the seizure lasting for 60 minutes was called as a status epilepticus. And later in 1993, ILAE first time has given definition for 30 minutes, seizures lasting for 30 minutes as a status epilepticus. American Epilepsy Society has given in 1993 has given 10 minutes. The latest, whatever has been operational definition, like the current practical or operational definition for status epilepticus is any seizure lasting for more than 5 minutes is a status epilepticus. And or if you can see this way also, if any child who comes to your ear in terms with the seizures can also be considered as a status epilepticus. So it's nice, it's good that we talking about 5 minutes, 30 minutes, 60 minutes. So we should have a funda for why we called 5 minutes, 30 minutes, 60 minutes. So the reason for this 5 minutes or 30 minutes is, so usually if you had any seizure, if anyone is having seizure, you have an internal mechanisms to control the seizures. So your internal mechanisms will in the brain will suppress the seizure activity within 4 minutes. If at all the seizure is going beyond 4 minutes or 5 minutes, then they are unlikely to remit spontaneously. There you need the medical help. So hence the concept of 5 minutes has come. So if you see the 30 minutes concept is, if a seizure is lasting for more than 30 minutes, then there will be a lot of pharmacological resistance to your anti-epileptics, and that is also, and this prolonged seizure for more than 30 minutes will cause neuronal damage, and that is the reason you have got this concept called 30 minutes. So ILE 2017 or 22 was also with this has given two important points to us, that is one is called T1 and T2 in status epilepticus. As we have discussed, T1 is the point, the internal mechanisms responsible for your seizure termination are failed, leading to prolonged seizures is called T1. T2 is the point beyond which you will have long-term neurological sequences in terms of neuromorbidity, be it neuronal death or neuronal injury, or you have having a lot number of neuromorbidity complications beyond a point, that is T2. So how does it clinically help to us? Like T1 is the point by which your treatment should be started, because they are not going to resolve spontaneously. Hence, by this time, you should start your treatment. Second, T2 is the point by which your seizure should be controlled to prevent the neuronal damage. So T1 for the treatment to start, T2 is the point by which your seizure should be controlled. If you see, is this T1, T2 concepts hold for everyone, for all seizures? No. Like if you see for generalized tonic-clonic seizures, the T1 point is 5 minutes. Your treatment should be started by 5 minutes before. T2 is by which your seizure should be controlled. That is 30 minutes in generalized seizures. Focal seizures, T1 is 10 minutes, 60 minutes for T2. For absence seizures, you don't have T2, you have T1, that is around 10 to 15 minutes. These are the important concepts which we should understand in order to manage a cases of status epilepticus or refractory status epilepticus. So, let's go to the further definitions. We have spoken about status epilepticus, then we'll talk about the other definitions, that is refractory status epilepticus and super refractory status epilepticus. Refractory status epilepticus is like you have a seizure despite on two anticonvulsants at good doses and first being a benzodiazepine. And if it is a GTCS, it should have a duration of 30 minutes. Then it is called refractory status epilepticus. Whereas to label someone as super refractory status epilepticus, the status epilepticus should last for more than 24 hours, or if someone is on IV anesthetics and despite on that you have a seizures, or when you are weaning off these anesthetics and you had a seizures, that is called super refractory status epilepticus. These are the definitions. And non-convulsive status epilepticus, you have certain child who is having persistent uptended or comatose state, and no, that is the time you will think in the terms of non-convulsive status epilepticus. And the better way to find out is getting a continuous EEG monitoring. There is a time you will find out in electrical activities. So this is pure neuro concept. This is nausea and fires. Nausea is like new onset of refractory status epilepticus, which is not explained by your structural damage to the brain, or metabolic causes, or you have a pre-existing neurological condition. That is called, you don't have any of these three, like structural or metabolic or a pre-existing neurological condition. That is a nausea. It is more of a clinical diagnosis rather than it's more of a clinical presentation, not to pertain to this is a specific diagnosis. So with this, these are the terminologies or definitions we wanted to talk. Now we will talk something called a time is brain concept. What is this time is brain concept? We have briefed a bit previously. Now we'll go into a little more details. For a seizure to convert into status epilepticus, if you see, for a seizure to for a seizure to convert into status epilepticus, initially you will have a receptor trafficking. What is this receptor trafficking? You have GABA receptors over here. You have GABA receptors over here, and you have a glutamate receptors. So GABA are inhibitory, glutamate are excitatory. So this is before status epilepticus. And if you see after a continued status, your GABA receptors which were there, they got internalized. See, your GABA receptors got internalized. See, once your inhibitory receptors like GABA are internalized, then you don't have receptors for inhibitory action, and that is the time you will have what you call decreased GABA receptors, and you have increased excitatory called NMD or AMP. So this is how it progresses from seizures to the status epilepticus, and that is the reason we say time is a brain concept. If you don't act within a duration, so there is even if you put on multiple medications, the response to these medications will not be optimal like the way it should happen before. Hence time is a brain concept. So this is secondary to one is we have discussed internalization of GABA receptors, and second there will be overexpression of this MDR or MRP1 receptors. These are transport receptors which will throw out your anti-epileptics out of the blood-brain barrier from the brain. So thereby you will have a pharmacological resistance. So that is why we say time is brain concept. So you act immediately, then the seizures a response to anti-epileptics will be good. So what happens if your seizures status epilepticus is not controlled? What happens to the brain? So in a prolonged seizures, you will have a massive glutamatergic activity, which leads to more calcium influx, which would lead to apoptosis or necrosis. So to say hence, in order to prevent this excitotoxicity, all electrographic activity should be suppressed. So, this is for the brain. So now, since because of excessive glutamatergic activity, that results in necrosis or apoptosis, right? The same way, if the status epilepticus was going on, you have multiple systemic complications. So cardiovascular, right? You can have a hypotension, cardiac arrest, arrhythmias. You can have apneas. You can have aspiration pneumonias. Multiple seizures leads to rhabdomyolysis, which can leads to AKA. You can have autonomic dysfunction. And all metabolic complications, including hyper or hypo or dyselectrolemia, can happen with prolonged seizures. So with this, we should understand time-dependent development of pharmacological resistance secondary to GABAergic activity. So hence, the important thing that more the seizure duration, more the complications. More delay in the initiation of management, more the time the child will have a seizures. So hence, we should make this funda point very clearly that terminate the seizures as soon as possible. This is about the basics. Now, I will not go through the classification of status epilepticus. ILA 2015 or 17 has given similar classifications. So, based on the semiology, etiology, and EEG correlates, the classification has been given. How do we manage management? This is more important. So, in seizures, the most important thing is management compared to the investigations. Our goals of therapy is a rapid termination of both clinical and electrical seizures, giving a neuroprotection, and preventing the prevention and treatment of systemic complications secondary to seizures and antiepileptics. So rapid termination, having good neuroprotection, and prevention of complications secondary to seizure or antiepileptics. Always your airway breathing circulation comes first. There is no doubt about it. And here, pharmacotherapy is much pharmacotherapy has more priority over the investigations in management of status epilepticus. You will protect your airway by airway, breathing, circulation, and you will treat all your ABCDs. You will address those issues. And after that, you will give medications. If at all you ask me what are the diagnostic workup, so I said pharmacological therapy is more important than diagnostic workup. If at all we need to know about the diagnostic workup, so if someone is having febrile less than 5 years and post seizure child is absolutely fine, conscious gained within less than 1 hour, so then you will think in the terms of febrile seizures where you don't send any investigations. If it doesn't happen like this, you will think in the terms of probably meningitis. You'll send all your infective workup, and also you'll plan for a lumbar puncture to look for the meningitis. If at all you have a immune component being involved, then you will work up for your immunologist sending all the antibodies, or if at all you can send NMO, MOG antibodies. Those can be sent if you're thinking in the terms of non-infectious encephalitis. Now comes to the pharmacology. From next onwards, whatever I discuss are based on American American Epilepsy Society 2017, ILA 2022 and 2023, and Association of Child Neurology 2014. So this has been given. So if someone has come to here with seizures, the treatment of early status epilepticus is benzodiazepines. Now the question comes is, so which benzodiazepine to be used? Lorazepam, diazepam, midazolam. So what are the various guidelines or systematic reviews told about this? So there is ILA 2015 has said lorazepam, diazepam, clonazepam, phenobarbital has no difference in the seizure control. Even American Epilepsy Society also has said the same thing. So in conclusion to all these guidelines, what has to be the level 1 evidence is first line anti-epileptic for a seizure is you can give intramuscular midazolam or IV lorazepam or IV diazepam. All three have equal efficacy to control the seizures. If not feasible, then yes, we can give buccal or nasal. Nasal midazolam is something which we use very often. You have to give 0.2 mg per kg. That is around 2 puffs in each, 2 puffs for every 5 kg. If it is a 10 kg child, then you have to give 2 puffs in each nostril. That is around 4 puffs. This is about the first line medication for seizure is very clear, so that you can use intravascular IV lorazepam, IM midazolam, or IV diazepam, or you can use nasal midazolam, right? So now the question comes is, now you have given midazolam, the seizures are not controlled, and what is the second line AED that you want to think of? So you have multiple medications like phenytoin, fosphenytoin, valproate, levetiracetam, phenobarbital, lacosamide. There are multiple medications to use as a second line. So now, what are the evidences suggesting about it? So if you see seizure that is published in 2014, seizure 23, that which has showed that there is no evidence to support the routine use of lacosamide, and valproate, levetiracetam, phenobarbital can all be used as a first line therapy. This is in 2014, where they said there is no evidence to support the routine use of lacosamide, but the guidelines have been changed and the practice have been changed significantly. So ILA 2015 has said similarly again the same, that phenytoin, fosphenytoin, valproate, levetiracetam, lacosamide have got the equal efficacy to be used as a second line, and which the evidence does not support. All these trials also does not support choosing one over the other. Having said the same, what is the practical things that is happening? So the practical thing is, if you are thinking in the terms of epilepsy syndromes, remote symptomatic epilepsy, those epilepsy syndrome, your second line anti-epileptic would be after midazolam or lorazepam would be an valproate. Obviously, if it is less than 2 years, if you are thinking in the terms of liver or metabolic cause, you will not think in the terms of valproate. If you have a renal failure, you will avoid levetiracetam. So most of the times now, recently, the most of the people's practice have been changed from phenytoin or phenobarbital to a levetiracetam as their first line and what we call second line anti-epileptic, followed by lorazepam or midazolam. Now, refractory status epilepticus. So again, from here, it is it is completely practice-based guidelines, where you don't have completely evidence-based. They are not evidence-based. So your options would be midazolam infusion, propofol, ketamine, thiopental, pentobarbital. We'll just go through them. So you have given midazolam, or you call lorazepam, then you have given a levetiracetam, probably around 40 mg per kg bolus that you have given. Now still there is an episode, still the seizures are ongoing. What is your next option? Will you consider mini bolus of the same levetiracetam, or will you consider another second line drug like be it fosphenytoin, lacosamide, or phenobarbital, or will you consider IV anesthetics? What to be used? This is a question everyone must know. For this, we'll try to go through few literatures. Then where it is like this literature from ILA 2015 2016 has not given any clear cut evidence to it, but uh, but going through multiple practical aspects also, if your PICU is available, go for intravenous anesthetics. PICU is not available, then consider another second line antiepileptics for a seizure where your first line second antiepileptic did not work. So you have used levetiracetam, where the seizures at good dose of 40 mg per kg, it didn't help you. If your ICU is available, probably you start on midazolam infusion or anesthetics. If it is not, if you don't have a PIC available, to that point, we can consider using another second anti-line, be it lacosamide or valproate can be considered. What are the therapies for refractory and super refractory status epilepticus? So if someone is going into refractory status epilepticus, few options that we need to consider is a midazolam infusion. So midazolam infusion, you can start at around 2 to 4 microgram per kg per minute. You can go up to 24 microgram per kg. Most commonly used IV anesthetic for control the seizures. So where you can go up to 36 microgram per kg per minute also. But if you are going beyond 4 to 6 microgram per kg per minute, so this child needs a ventilation. This child needs a central line. These are the things that we should keep in mind. Thiopental is a wonderful drug to control the seizures. the moment you start on thiopentone, you will definitely see most of the times you will see a good response to control the seizures, because it activates your GABA well and it inhibits the NMD receptors. The problem with thiopentone, significant problems with thiopentone is, number one, it causes significant hypotension. You land up in giving, most of the times, giving what do you call, inotropes to maintain your BP. Second, you will have a lot of immunosuppression leading to secondary bacterial viral, secondary infections. Third, it suppresses all your brainstem reflexes. You will not be able to monitor your, because you see the pupils might be dilated. You will not see any of your brainstem reflexes when you are on high doses of thiopentone. Probably these days we are not using thiopentone. We are using midazolam infusion. Then followed by, most of the times the choice would be more for a ketamine infusion. So pentobarbital is also, most of the time, it is commonly used to control the seizures, where you can start at 5 mg per kg per minute to up to 10. Your the end point is to induce a barbiturate coma, which can be seen in your EEG. Propofol is not commonly used for pediatrics, because many people say, although I have not seen many people say that the propofol infusion syndrome is a complication to this, most of the people do not prefer propofol infusion. This is commonly used. If you ask me, post midazolam infusion, after midazolam infusion, the most commonly used for in refractory status epilepticus is ketamine infusion. So it has got good hemodynamic properties, good hemodynamic stability. It has got NMD antagonist, and there is you have got good neuroprotective with this ketamine. So you can start around 2 mg per kg per hour to 7.5 mg per kg per hour. So other additional drugs that you can consider is pyridoxine and topiramate. Hypothermia has got no significance in management of seizures till to the evidence. No evidence to use hypothermia in children for seizure control. Ketogenic diet is most commonly used these days. Post one seizures not controlled, most of the children are on ketogenic diet. Someone is on a super refractory or refractory status epilepticus after your midazolam or ketamine infusion. Most of the children we start on ketogenic diet. So the things that you have to consider is, like, this is a problem with you can have lactic acidosis, metabolic acidosis, gut issues. This can be a problem secondary to ketogenic diet, where we have to monitor. So other potential therapies is like lacosamide is recently commonly used drug to control the seizures after levetiracetam. Although you don't have clear-cut evidences, is coming decently. So one of the most commonly used post levetiracetam is lacosamide. So neurosurgery to control the seizures, unless you have a structural lesions like focal cortical dysplasia, neurosurgery do help in such scenarios where FCD removal will help in controlling the seizures. So the question is, when to do, you said, like we said, like pharmacotherapy is most important compared to the diagnostic. When should we consider a neuroimaging? If you have if you have a new onset focal deficit, like an emergency imaging is done when you have a new onset focal deficits, persistent altered awareness, history of trauma, or you are suspecting that there could be a bleed in the brain or some tumor, then you will think of neuroimaging on an emergency basis. If you're thinking of non-convulsive status epilepticus, or you're managing a patient of refractory status epilepticus, you should have a continuous EEG monitoring. So my takeaway points would be, KIMS brain concept, control the seizures as quickly as possible, pre-hospital treatment, early effective treatment to prevent morbidity, neuromorbidity and mortality. Always your ABC will come first. Have your cerebroprotective measures when you're managing any child who has got neurological issues. A swift escalation and adequate dosing of anti-epileptics without any delay is the cornerstone management of status epilepticus. With this, I will conclude. If at all any queries, I don't know how it works over here. I think we can discuss also. If someone has any queries, we can discuss over here.
Dear Dr. Suman,
Anji sir.
yeah, very good, very nice presentation, excellent.
Thank you,
All
sir.
your messages are very good takeaway messages.
Yeah.
And please clarify me one doubt.
Yeah,
Why not
please.
IV metazolam? Why only you stressed IM metazolam? Please
No,
kindly
it's not like that, sir. No particular reason, sir. It is only the study of that showed that IM midazolam is easy to give. So that is the reason they said IM midazolam. It is only the study perspective I told you, sir. But as such, the most commonly used is IV midazolam only. Availability is more easy, so IV midazolam is most commonly used. But if you see the literature which I was quoting you, ILA 2022 and the previous, I'll show you the results as well. I was telling you only about the results part.
Usually in the periphery, we are at periphery and rural setup, we have been working for last 35 years. During the seizure attacks, the tonic-clonic seizures still are there. What we do, we stabilize the patient, put on oxygen, remove the secretions, and we will give IV midazolam or diazepam, whichever is available still the if it's lost. If it is persist, we go for IV levetiracetam. Is it true? We can continue like this?
Yes, sir. If you any child coming to your ER with seizures, we will consider that as status epilepticus. If you are having a Midas nasal spray, I think you can put Midas nasal spray, 2 puffs in each for every 5 kg. If it is a 10 kg child, you can give 2 puffs in each nostril. That makes 4 puffs. That is good. Hello?
So during the acute phase, we can give IV diazepam or IV midazolam.
Yes. If you have IV cannula, you can give IV lorazepam or IV midazolam to control the seizure immediately. Then you can consider IV levetiracetam at a good dose, sir. Not less than, see, the dose is 30 to 40 mg per kg minimum. So no 20 mg per kg. So if you're managing status epilepticus, go for 30 to 40 mg per kg. Actually recommended is 40 mg per kg. Don't worry about the dose also. I've written the dose also over here. The maximum dose that you can give is 4,500 mg per dose. This is the dose that we can give also. But usually you don't give more than 1 gram, but if at all required, you can go up to 4,500 mg also. 4.5 grams is the ceiling dose. So yes, so you can give IV midazolam or IV diazepam or Midas nasal spray, then followed by levetiracetam at a good dose of nearly 40 mg per kg. And if you're not getting response to 40 mg per kg of levetiracetam, then you will choose another second line anti-epileptics if you don't have an ICU. If you have an ICU, probably that is the point we'll think in the terms of IV anesthetics. If you have no ICU, then you can give another second line anti-epileptics. These days, we are using lacosamide post levetiracetam. We are using lacosamide 5 mg per kg, 5 to 6 mg per kg is what we are giving. You can choose a valproate also. You can choose a phenytoin also. You can choose, sir. That is there.
Okay. Thank you very much, Dr. Sumanji. And one thing, when we are giving midazolam, since midazolam is little long acting, the neurological examination of the child is a bit difficult.
True, sir. True.
Following midazolam. And diazepam is short acting, immediately they can be arousable. Is it true, sir?
It's not like this, sir. Both will take the similar time for the recovery from the this what do you call from the sedative effect of whatever the things that we use. It is nearly the same only. In fact, lorazepam will have little longer duration of action. So yeah.
Thank you, Dr. Suman. Very nice presentation. Good. Thank you very much.
Sure, sir. Thank you, sir. Thank you. Any other queries? So if at all no queries, then we'll end the discussion. We'll close the session. Thank you. Thank you for time.